Dr. Sushmita is a professor at the Advanced Eye Institute, Chandigarh, and she is not only a versatile surgeon, a prolific speaker, and a great teacher. So over to you, Sushmita, for learning gonioscopy. Gonioscopy versus UBM.
Thank you so much at the outset, Dr. Chandrama, GSI and AIOS for having me on. I'll be talking on gonioscopy versus ultrasound biomicroscopy with no financial disclosures. There's no debate actually, because I think it's quite obvious. The outline in the next couple of minutes, we'll look at vital insights for diagnosis versus questionable information, feasibility and ease versus equipment, what is the evidence, and what do all the experts say. So gonioscopy is the gold standard against which all anterior segment devices are evaluated, whether it is a UBM, whether it is the ASOCT, they're all asking the question of whether or not it is as good as a gonioscope for evaluating the angle. There's no question about the ease, cost, and feasibility of gonioscopy, where one of my favorite pictures of doing it in a 3-year-old girl versus the bulky and the big instruments that we need to have. If at all there's a debate, it would be probably in primary angle closure disease, because Asians will represent 87% of those with ACG by 2020, and this is an old study, so now I'm not sure how much they do represent, and 91% of people bilaterally blind are with PACG. So when we acquired the UBM, we looked at, and we were sure that the objective method would be better, but when we evaluated the anterior chamber angle in Indian eyes by UBM and gonioscopy, we were quite astonished to know that gonioscopy actually scored almost as well. So we learned that we don't need imaging to tell us if the angle is open or closed. What about in plateau iris? Yes, of course, the UBM brings it up beautifully. You can see this knuckle of ciliary body pushing up the iris to close the angle. But then a double hump sign observed on indentation gonioscopy was strongly correlated with the presence of a plateau iris or UBM. So plateau iris configuration, if you look for it, if you're wondering why your pressures have not come down after an LPI, for instance, and if you just do an indentation post LPI, you would see this knuckle of ciliary body which is pushing up the iris against the angle. So gonioscopy can do that as well. But then a gonioscope is indispensable if iridocorneal trabecular contact is present, whether you want to know whether it's appositional or synechial. So this appositional closure would look like this on the ASOCT, but the ASOCT is not going to tell you whether or not this will open up on indentation, whereas your gonioscopy, you just need to press it. You can see these Descemet's folds, the cornea, and you can see the trabecular meshwork which is visible. What about its utility in trauma or say pigment dispersion? So this is a cyclodialysis cleft, which I can see with gonioscopy, but I can also image with UBM if I want. Plateau iris is shown up nicely on the UBM, of course, but then you can see concave iris configurations, and post LI, this is what happened to the iris and this is what happened on the UBM. Whereas angle recession and cyclodialysis is demonstrated well, but then you could do all of this with a gonioscope as well. So do I need the UBM to tell me all that? And how would imaging show a subtle Stampa-Ulysses line in pseudo-exfoliation or a painted trabecular meshwork as we see in pigment dispersion syndrome, or a blood in Schlemm's canal in Sturge-Weber, or broad-based peripheral anterior synechiae in uveitis to be differentiated with the characteristic iris processes in an Axenfeld Rieger. So there's no question that for qualitative angle assessment, you need the gonioscope and you can't have it on the UBM. To carry on, how can imaging show you Coben reeds? These are iris nodules or peripheral anterior synechiae in Chandler's, or a neovascular glaucoma, or even emulsified silicone oil in the angle after PPV. But now let's see the evidence. So big question, is it useful for screening? And I just pulled out these papers comparing the gonioscopy and screening tools for angle closure. So here you have 2,000 plus subjects screened for narrow angles using a peripheral anterior chamber device, an IOL master and ASOCT. and gonioscopy was the reference standard. So the sensitivity and specificity of all these equipment were less compared to a gonioscope, and the low specificity may limit the usefulness of these devices in screening for narrow angles because you're going to miss them. Again, to detect PACS, 425 eyes were taken, diagnosed by gonioscopy. They used the Van Herrick, the ASOCT, and the Pentagam. Now, the ASOCT had the specificity of just 87% and the Van Herrick of 92%, but none of these tests evaluated achieved a combination required for a population-based screener. Is it observer independent? A scleral spur could not be detected in approximately 30% of anterior chamber angle in any of the quadrants. Now, if you don't detect a scleral spur reliably, none of these equipment is going to tell you anything about your anterior chamber. So this is a nice comparison of a Visante ASOCT, which easily gave a lot more penetration and a lot more angle assessment, Cirrus ASOCT and gonioscopy. So angle closure was detected in 18%, 16% and 48% of quadrants using the three respectively. The scleral spur was identified only in 56 and 50%. Now these are by people who are looking for the scleral spur. So I'm not even looking at a garden variety everyday glaucoma clinic. And a slight agreement with gonioscopy, very slight with Visante and Cirrus, but a good agreement in angle closure assessment across examiners. So clinical examination with gonioscopy, even then, is better than the others. And then what do the experts say? This is the WGA consensus statement. I'm sure all of us have read that. Gonioscopy is indispensable to the diagnosis and management of all forms of glaucoma, not just PACG, and is an integral part of the eye exam. And I love this part. Anterior segment imaging may augment the evaluation, but their place in clinical practice needs to be determined. Now, don't get me wrong. Imaging is indispensable in certain situations where gonioscopy doesn't have the answer, but it's not a replacement. It's complementary. And we've seen this in many, many eyes. I mean, UBM in childhood glaucoma has changed the situation for us. We've made wonderful diagnosis based on the UBM. We've published on all sorts of things on why the UBM is essential, but it's not essential for looking at the angle. So to conclude, gonioscopy remains indispensable. Imaging devices are not without their limitations. Anterior segment imaging may be revolutionizing angle closure assessment, but clinical dynamic indentation gonioscopy is the way to go, and they augment clinical practice and are useful tools. But there's no versus with gonioscopy. Thank you. Thanks a lot.
Thank you very much, Dr. Sushmita. That was indeed a very, very relevant, salient take-home message given about gonioscopy and the UBM. So we'll